I do have a lot of information in this talk, and I'm hoping that it hits on a lot of the questions that you guys may have had about coagulation sort of leading up to this. So with that, we'll just kind of dive right in. Oh, you guys, I do also have 2 polls for you that we'll get to right after the first slide. Really, I'm going to want to know just a couple of answers for you. They're not too long. So let's begin. Okay, so we're going to start this discussion with an overview of hemostasis. We're going to talk about both primary and secondary hemostasis. And then, move this to there you go. That's better. And then we're going to move on into blood clotting, and we're going to go through some physiology. Physiology, clotting physiology can be a little confusing and it can be a little bit dry, but we're going to sort of pepper this talk with some case-based discussion toward the end as well. We're going to dive into some testing modalities, kind of going through some of the old school testing that we've traditionally used for a long time, and then diving into some newer testing modalities that we have available to us in veterinary medicine, which we've adapted from human medicine. It's kind of fun to discuss the ways in which human medicine uses this testing and now how we're using it. We're going to discuss some therapeutic options for coagulopathies, and we're also going to focus on transfusing products, because that can be a point of confusion, I think, for a lot of people. What do I transfuse and when do I transfuse it? We're going to discuss both hypercoagulable problems and hypocoagulable disease processes. And then, again, we're going to end with some case examples. So on that note, we have a poll. So our first question, what I'd really like to know from you guys is, what kind of coagulation testing do you have available in practice? And I'll give you some time to think about what you have and answer the question, and then hopefully we can share that information with everyone. All right. Excellent. This is really interesting information. So it looks like a large percentage of people have PT and PTT available to use. Some people still have BMBT available. So that's excellent. We're going to talk a lot about PT and PTT in this discussion, so you can see really where the value is in your clinical cases and utilizing those tests. Second poll. So our second question is, do you use blood transfusion products in your clinical practice? And that's really any transfusion product. That can be fresh whole blood that maybe you get from a donor, or packed reds, plasma, albumin. That's great. So I see it's not quite half and half, but close. I'm so happy to hear that people are using transfusion products in practice. Obviously, there's a great need for packed red cells, but plasma is really easy to use as well. And as you'll see in this talk, you can store it for a long time. So I'm so excited to hear that. All right. Okay. All right. Okay, you guys, so let's kind of jump in. Okay. All right, there we go. So let's talk about hemostasis. We're going to dive right into primary, and we're going to talk about secondary hemostasis. So, you know, when we were all first learning about clotting, we learned about primary versus secondary hemostasis. And truly, primary hemostasis is that initial platelet plug. So there's an injury that occurs with the endothelium. The endothelium contacts the blood, and then there's that initial platelet plug that forms. You have the addition of various clotting factors that migrate in, and then there's this sort of downstream cascade that then causes that secondary hemostasis to occur, which we'll talk about on the next slide. But diseases that affect primary hemostasis are going to include thrombocytopenia, so low platelet numbers. And this picture is an example of a dog with petechia from thrombocytopenia. And that's probably one of the best pictures I've got of petechia. Sometimes they can be a little more subtle than that. So when you have a dog that you suspect may have low platelets, you always want to, or a cat even, you always want to look really closely for those petechia because initially they can be really hard to see. Primary hemostasis disorders also include thrombopathias. So when we talk about thrombopathia, we're really focused on a dysfunction of the platelet itself. And there are lots of things that can cause platelet dysfunction. Very typically in the classic example is going to be a dog, or I suppose a cat that has had an NSAID, because of course NSAIDs will inhibit thromboxane, which is necessary for platelet activation. So if you know, you've got an animal whose platelets aren't working, they will clinically behave the same as a dog or a cat with thrombocytopenia. And then finally, the third big example of a disorder of primary hemostasis is a von Willebrand's dog, typically. Although von Willebrand's disease, as you'll see later, can also behave as a disorder of secondary hemostasis as well. Secondary hemostasis really includes all of those clotting factors that we talk about and the development of that fibrin meshwork. And there's a lot involved. We're going to go through the clotting cascade, how we all learned it in vet school, and touch on that a little bit. And then we're also going to focus on what's called the cell-based model of coagulation, so that we can, in greater detail, really talk about the role that the cells actually play in the formation of the blood clot. But disorders of secondary hemostasis are going to include things like factor deficiencies. So hemophilia A, for example, which is a deficiency in factor 8, or hemophilia B, which is a deficiency in factor 9. And then we're also going to focus on vitamin K deficiencies with secondary hemostasis, because of course vitamin K is necessary for a lot of clotting factors. So those animals that have low levels of vitamin K, for example, are going to have a clotting deficiency. And remember, vitamin K is a fat-soluble vitamin. So if you've got an animal that has, for example, a problem with bilirubin outflow, bile outflow into the GI tract, those guys are not going to absorb vitamin K well. And so those animals will have a relative vitamin K deficiency, and that may contribute to a coagulopathy in those patients. Vitamin K antagonist rodenticides are also going to be included in that category. And again, von Willebrand's disease raises its head here too, because von Willebrand's factor works with factor 8. And so that's going to contribute to a secondary hemostasis problem. When we all learned about clotting, we learned about clotting via the clotting cascade model. And it's what we're familiar with. What's interesting about the clotting cascade model is that while it helps us to really understand clotting on a basic level, there are a lot of holes in this cascade model because there are a lot of redundancies in it. And if you look at this chart of the cascade model, really there's a lot going on here. And you would think that if there is a deficiency in one of these factors, for example, it completely collapses the whole cascade. And I think the best example of why the clotting cascade may not be 100% explanatory when referring to clotting is that if you take factor 12 out of the animal, okay, so for example, if you've got a cat that has a factor 12 deficiency, and there's factor 12 way up here at the very top, that's also called Hagman factor. A factor 12 deficiency does not cause clinical bleeding at all. And so you can have a cat, for example, that has no factor 12, but has completely normal clinical clotting. They may have an abnormality in a test, for example, but that doesn't correlate to clinical clotting deficiency or problem. And in fact, dolphins and whales don't have factor 12 at all. And obviously they're just fine, which is pretty cool. Now, what is helpful regarding the clotting cascade is that it helps us when we look at these various branches of the cascade, so the intrinsic branch and the extrinsic branch. It helps us to understand our tests. So PT, PTT, and activated clotting time. These tests are going to evaluate different branches of the clotting cascade. Now, what we do know, and what this also displays to us, is that calcium, and what's important to point out here, is that calcium is absolutely necessary at each step in the clotting cascade model. And that's certainly an absolute necessity. Now, which of these factors are vitamin K dependent? We're going to move into vitamin K dependent clotting factors and what it means to be dependent on vitamin K. I'll give you guys a minute to think about that. And here in a moment, we'll have our answer. You want to remind them if they have a question to type it in. Oh yeah. Heidi, who's really good at this sort of thing, is asking me to remind you all, if you do have a question, please type it in the Q&A box. I don't know how to do that, but I'm sure it's easy. Yeah, it is. You guys can figure it out. Okay. So yeah, think about which factors may be vitamin K dependent, and then we'll have our answer here in a moment. Oh, do I have to click something? Yeah, okay. So what does it mean to be dependent on vitamin K? Well, vitamin K, and this, it's odd to think about this, but vitamin K is actually an enzyme, right? So vitamin K is necessary for certain factors, certain clotting factors, to be activated. And the reason is that vitamin K actually carboxylates, so it adds a carboxyl group to some of these clotting factors in order to activate them. So vitamin K is an enzyme, it adds this carboxyl group, activates a clotting factor, and then that clotting factor can then do its enzymatic job, which is pretty neat. Vitamin K was an enzyme, who knew? So when vitamin K activates a clotting factor, it essentially develops into what's called an epoxide. So it goes from this active form into this epoxide version. So then vitamin K is no longer functional to activate further clotting factors. So what do you do about that? Well, you essentially want to reduce it again. So you've got this other enzyme in the body called vitamin K epoxide reductase. And that enzyme acts on that inactive vitamin K to activate it. So then you can basically recycle the vitamin K and use it again to activate your clotting factors. Vitamin K antagonist rodenticides, for example, they make this enzyme non-functional. So this enzyme that sort of recycles the vitamin K and makes it work again doesn't work. And that's why you get coagulation abnormalities with vitamin K antagonist rodenticides. Something that everyone wants to know about, right? Ooh, there's a question. Dr. Black says, are we talking about vitamin K1? Yes. we are talking specifically about vitamin K1. So that is the enzyme that we're looking at here. So K1, you got it. And does K2 participate? And the answer is no. So we're looking at vitamin K1 here. Great question.
Seems like anytime you touch the touch pad.
Okay, technology. Oh my goodness. Okay, so vitamin K dependent factors, that's the question we were thinking about earlier. So those vitamin K dependent factors are going to include factors 2, 7, 9, and 10. Those are our vitamin K dependent procoagulant factors. Now, interestingly, and this isn't something that people think about very often, there are some anticoagulant factors that are vitamin K dependent too. So if you've got a relative vitamin K deficiency in an animal, you may have a deficiency with coagulation and develop bleeding, which is what we tend to see clinically. But interestingly, there are also vitamin K dependent proteins which help with anticoagulation. So that includes protein C, protein S, which both participate in anticoagulation, but also protein Z, which we don't know anything about. We really don't know what protein Z does. We just know it's vitamin K dependent. But protein C and S are anticoagulant factors, so there's always a chance that you might see some procoagulant pathology in animals that have some degree of vitamin K deficiency. And really, you're going to be thinking about animals with liver disease. So again, rodenticide toxicities are not going to display that clinical presentation. So looking at our tests, moving on into our tests to evaluate coagulopathies, the prothrombin time is something that it looked like a lot of you guys have available in practice to evaluate. So that PT, prothrombin time, is going to evaluate extrinsic and common pathways of the clotting cascade. So when you look at the cascade model, it helps us to understand what the PT does clinically. And essentially that PT is going to evaluate factors 1, 2, 5, 7, and 10. Now that's really important because factor 7 here is the clotting factor with the shortest half-life. So if you've got a rodenticide toxicosis, for example, that factor 7, its half-life is only about 6 hours. So even before you get a prolongation of PTT, and even before you get clinical bleeding in a rodenticide toxicity, you're actually going to see a prolongation in your PT, which is why we have animals checked for PT time after toxicosis. And usually we're going to do that 2 to 3 days after the potential ingestion occurred. So that's the PT, or prothrombin time. Now, PTT is helpful to evaluate a lot of different clotting factors, and we also use it to help us determine the effectiveness of heparin therapy. Heparin therapy is tricky, and evaluating whether it's effective and at appropriate levels can be challenging, but PTT can help us to determine if we're using the right dose or not in our patients, so it's valuable in that respect. And PTT is helpful in evaluating the intrinsic and common pathways. It evaluates, that PTT evaluates basically all of the clotting factors except for factor 7 and 13. So it's a really important test that we utilize in clinical practice. Now the ACT is something that we really don't use very often anymore because it's fairly redundant if you have PT and PTT available. Obviously it's the activated clotting time, and it evaluates the intrinsic pathway and the common pathway. PT and PTT testing have some drawbacks, which is really why additional coagulation testing has been created and clinically utilized initially in human patients and then now in veterinary patients. And that's what I'm really excited to get to toward the middle of this lecture and the end. But the drawbacks of the PT and PTT include the following. Really, it doesn't evaluate, they don't evaluate von Willebrand's factor appropriately. So if you've got a patient with von Willebrand's disease, you can run a PT, PTT, and those can be completely normal, and the animal will have clinical bleeding, can have clinical bleeding. Now, if that patient has bled a lot and has consumed clotting factors, in addition to being low on von Willebrand's factor, you will start to see some elevation in PT, PTT. But early in the process, you may have a von Willebrand's patient with a totally normal PT, PTT that is going to be at huge risk for bleeding, for example, during surgery. PT, PTT also doesn't evaluate the contribution of cells at all. So there is a contribution, obviously, of platelets and these little circulating cell pieces called microparticles. And it also doesn't help evaluate or assess for platelet activation by various cytokines in the body either. So essentially, it's great to know what platelet numbers are. It's great to know what PT and PTT are, but there really are a lot of holes in those testing abilities to evaluate clotting globally or clotting in the patient. PT, PTT also don't assess for fibrinogen, which is really important. That's the protein that is a precursor for fibrin, obviously, and that's really our meshwork of clot. Prolongation of the PTT, as we talked before, happens with a factor 12 deficiency, for example, in cats. And there's really no clinical correlation to that at all. So, for example, another confounding factor when evaluating PT, PTT is that you may run coags on a cat and PT will be normal. PTT may be very, very prolonged, but you have zero clinical bleeding. And that's because those cats will have a factor 12 deficiency, which doesn't cause any clinical problems. And then, of course, if you don't fill your tubes very well, that can affect your outcome, your testing outcome. And these tests don't assess for clot breakdown dysfunction either. And that's a big problem in certain animals, for example, greyhounds. Some greyhounds can break down their blood clots really rapidly, and they bleed like crazy. And we'll go into that in more detail in just a moment. So because PT and PTT are not perfect tests, and because assessing platelet numbers is not a perfect test, and so you have these imperfect tests trying to evaluate a patient with clinical bleeding, you have to come up with another type of model other than the cascade model, which correlates with those testing modalities that we just talked about. And the other model that we're going to talk about, which really helps incorporate the cells and the contribution of the cells to clotting, is the cell-based model of coagulation. And that's really not something that at least I didn't learn about it in vet school, although that was a long time ago. And the interns that I've been seeing recently, these young guys with the new knowledge, they, from what I understand, they're not really learning about the cell-based model of coagulation in vet school, but it is out there in the literature, so I thought we would touch on that today. The cell-based model of coagulation is really a more comprehensive model of what's actually happening in the body. So it incorporates blood clotting factors, but also the interactions of the cells and what they do to the clotting factors and how they help the clot to really form and become strong. So the cell-based model is really comprised of 3 separate stages. The first being what we call initiation. So in the initiation phase, there's that initial injury to the endothelium, for example. And so the blood is exposed to, let's say, an endothelial cell, and we'll use this TF-bearing cell example to be an endothelial cell. So the endothelial cell is going to be exposed to blood. That cell bears tissue factor, so it has tissue factor on the outside of it. And essentially that creates the beginning of clot formation. And so you've got factor 7, which is then activated because of exposure to this tissue factor bearing cell. And then that causes activation of factor 9. And thrombin can then diffuse from that tissue factor cell to the platelet. And that's a really important step because that helps to activate the platelet. And as we know, platelets are extremely important in clotting. And that's going to lead us into the amplification or second stage of coagulation in this model, where the platelet becomes activated and can finally start to do its job here. The platelet's going to release some von Willebrand's factor, and essentially that's going to cause clotting to progress. Then we'll get activation of factor 5, 8, and 11. Which then leads us into the third phase, which is the propagation phase of the cell-based model. And so all of these activated enzymes, which we just referred to, are going to assemble on the platelet surface. And it's going to create this sort of enzyme complex, which essentially ends in the development of a bunch of factor 10A and a ton of thrombin. And thrombin is that factor which is so important for the conversion of fibrinogen to fibrin. And of course, fibrin is that meshwork of the clot. So that's that absolute necessary net that holds in all the platelets, all the proteins, and that's really how the clot forms. So in my mind, the cell-based model of coagulation really is a lot more accurate than the cascade model, and it incorporates a ton of these factors that are so necessary in understanding what actually probably happens in the animal itself. I clicked it. All right. So what kinds of tests do we currently have that evaluate for cells? So we have the BMBT, and I know some people have that in practice. We have some here and at AERC, and I honestly haven't used it in a while. I haven't used it probably for, I don't know, a year or 2 years maybe. But it's a really simple test. And the only reason I haven't used it is because we recently got a machine that I'll talk to you about in a little while that makes the BMBT probably unnecessary for me, but it's a really simple test. They're really cheap, and it evaluates for platelet function, which is really important. To use the BMBT, you really need, oh, I think I got rid of the question. There it is.
There it is.
I'm so sorry. I moved my question box. So if anybody has asked a question.
Nope.
Sorry. Oh, good. Perfect.
You're good.
So anyway, the BMBT, it evaluates platelet function. You want to have normal platelet numbers when using it, of course, and it'll also evaluate for von Willebrand's disease. So it'll be prolonged in patients that have von Willebrand's disease, low von Willebrand's factor. It is a screening test, and you know, it's easy to create user error with it, so you do have to be a little bit careful. Essentially what you do is you have this lancet and you want to put it on the mucosa and puncture the mucosa. And you blot below where the laceration is bleeding, but you don't want to touch the actual clot and laceration itself with the paper that we're using. And honestly, we just use coffee filters. So there's really nothing fancy involved in this test, and it's really inexpensive. So it's a good one to have in your practice. Looks like we have a question. Oh my goodness, there it is. There you go. Okay, so the question is, do you recommend this test for any Dobie having surgery? And my answer is absolutely, if it's the first time they've had surgery. And of course, that's the breed that is prone to developing von Willebrand's disease, and there are other breeds as well, but it's so prevalent in Dobies, and this is such an inexpensive test that I think it's wise. However, you have to be careful because you can get falsely elevated results if you're not doing the test really meticulously, and then that'll cause you to prolong an elective surgery or push back an elective surgery, for example. So you'll just have to be really careful about how you do the test, but I do think it's a wise idea, and it's really inexpensive, so it's something that would be good to offer to your clients. it's a test that's unnecessary if you've got thrombocytopenia, because we know that the BMBT will be prolonged in the face of thrombocytopenia. So, and normals in this test are less than 4 minutes for a dog, and published results include 1 to 2.5 minutes for a cat. But generally, I just say less than 4 minutes for both dogs and cats. What it doesn't account for are changes in fibrinogen, vascular changes, abnormalities with fibrin destruction or breakdown of the clot. It will not account for clotting factor deficiencies and will be prolonged in the face of that, or vitamin K deficiencies. And as we talked about, it is fraught with technical errors, you know, especially if you're touching the clot itself. So you do have to be a little bit careful with how you perform it. And sometimes you'll need to sedate your patient to do this. And that's really frustrating because, of course, certain drugs can affect clotting, but you can't really do this test in certain types of animals without sedation. So that's a bit of a drawback there. Okay. Now we're going to move into what I think is really interesting about this talk, and that's viscoelastic testing. And that's just the long word for what you guys may have heard about in other talks. That's thromboelastography. And thromboelastography is also abbreviated TEG. TEG is really the name for a certain type of machine that evaluates global blood clotting. And so the term for global blood clotting evaluation with a graph that looks like this is viscoelastic testing. This was really created because we know that conventional coagulation testing, it really only evaluates one portion of the hemostatic process. And what's great about viscoelastic testing is that it evaluates the clot globally. And what it's missing, what it doesn't evaluate, is blood flow. It doesn't account for blood flow, obviously, because this is a blood test that you put in a tube and run on a machine. And it doesn't take into account the effect of the endothelium. But that's really those are really the only holes in this form of testing. And there are many machines available. I'm going to go through those here in just a minute as well. But first, I wanted to focus on what this graph means when we talk about viscoelastic testing, and how it really helps us to make clinical decisions. So the things I think are most important to understand here with this brand new testing modality are, this is a graph that we see on a screen, and it runs for 60 minutes. So, you know, you'll put your blood sample in and the graph will start running, and then you have to be patient, which is really hard. It's so hard. It's very hard for me. And really, you're going to watch the clot essentially form in a graph form for 60 minutes. And you're going to be able to see how quickly the clot forms, whether it's a strong clot, and whether it breaks down really quickly or breaks down appropriately. So that's why the test takes so long. There are a couple of components to this that you'll want to be aware of. So there are certain values, and I'm using this particular example, and the values reflect that TEG or TEG machine. And as I said, there are multiple types of machines on the market, but this one is from the TEG machine. And that first value is called the reaction time. The reaction time, really, it helps us to determine how fast the clot begins to form. So it shows about pre-coagulation. It's going to help us to evaluate factor 8, 9, 11, and 12. The second value that we're going to see on a printout with an actual number is this K value, and it's on the graph. It's this value right here, and the K value is the clot formation time. It really shows us the distance between the end of the R value and then the point where these two lines here begin to separate. And that really tells us about the rapidity of clot formation. So how rapidly can this clot form in the animal? It's going to help us to evaluate factor 2, 8, platelet count, which is really important, obviously, thrombin, fibrin, fibrinogen. The hematocrit will affect it as well. So as you can see, there's a lot that goes into this graph, and it really helps us to evaluate a lot of different factors in clotting. The alpha angle is the next value to know about here, and really it is truly just an angle that helps us to know a little more about the rate of clot formation. And then finally, the most important value in my mind for most patients when we're looking at this testing is this MA value here, because it helps us to understand the strength of the clot. And that's probably the easiest one to see on a graph if it's abnormal or not, and so important in evaluating for clinical bleeding tendency. So those are all the procoagulant things to evaluate. And then of course, if you let this graph go, you can then look at clot breakdown as well, which is kind of cool. What this testing does evaluate, obviously, is primary and secondary hemostasis, as we just talked about. But it also helps us to understand anticoagulant components too, which none of our other tests really help us understand. So we can't gather that information off of a PT, PTT, CBC, or BMBT. And those anticoagulant components are really important in clotting. So this graph will help us to understand if a patient is hypercoagulable and might be throwing clots, or if they're hypocoagulable, obviously. So the components that it helps us to understand are things like antithrombin and protein C and S, whether they may be problematic, as well as plasmin activation. So here's one of the machines that are on the market, and some of these machines are really expensive. In fact, frankly, most of them are pretty expensive. The TEG machine, thromboelastography, it's really mostly available at universities. I don't really know of a private practice that has one of these. It might be out there, but I personally don't know where it is. And essentially how this machine works, it's a tabletop machine that, that has this pin, and you put a whole blood sample into this cup, and then the pin moves, and the torque created on the pin gives you the graph that we saw earlier. And then you also get a printout of specific times, like how long it takes the clot to form, how strong the clot is, and then, you know, how long it takes the clot to break down, that sort of thing. Oh, there's a question. I'm so glad you're here, Heidi.
Yeah,
Heidi's helpful.
Too.
Oh my gosh, look at that. Okay, so question number one is, what physical properties does the machine measure to evaluate the clot? The machine, every machine is different, and this one works off of the physics concept of torque in the clot. So as the clot forms and the pin is moving, it then, through some physics engineering thing, evaluates the torque, and that creates the graph. So essentially it's evaluating all properties of blood clot development. So how strong the clot is, how rapidly it forms, based on physics and biology, which blows my mind, right? I hope that answers the question. And if it doesn't, please feel free to ask it again or in a different way, or even email me. And then we have another question. For BMBT, is it necessary to use specific lancet? And what about a number 15 scalpel blade or an 18 gauge needle? And I think that certainly if you wanted to use a number 15 scalpel blade or an 18 gauge needle, that would give you a rough idea of whether your animal would have a bleeding problem or not. But the normal times that have been evaluated for BMBT, the normals that were created with a specific type of injury that was created in the mucosa to a specific depth, which is why those commercial BMBT kits are helpful, because, you know, you push it down and this little lancet goes into the mucosa at a specific distance and creates a very specific type of wound. And that's how the normals were created. So I think you could use a 15 blade or an 18 gauge needle or something if you wanted to get a rough idea. But if you really want to pay attention to normals, then the lancet's really how the normals were created. So I hope that answers the question. Good questions. Okay, so that's the TEG machine. We don't have that here at AERC. We also don't have this. This is the Rotom. The Rotom is like the competitor to the TEG, and that's what it looks like. It's, oh, I really like that picture a lot. It's nice and colorful. So the Rotom works similarly. All of these machines work similarly. And essentially with the Rotom, so if we looked at the TEG, the pin was the thing that moved, and then the machine evaluated the torque and created a pretty graph. But with the Rotom, the cup is the thing that moves, and then the machine evaluates the torque as the cup moves and the clot forms, and then creates the graph from that. So exact same idea. Probably the same people that worked to form all of this just went to two different directions and formed two different companies. I don't know. But in this one, the cup moves. Let's see, do I have anything else to say about that? I don't think I do. All right, moving on. But this is the machine that we have because it looked good at a conference, and then someone came out and there were a few of us that fell in love with it. It wasn't me. This is the VCM vet from the Integrion company. And I like it because it's really small. You can't really tell on this picture, but it's like, it's smaller than the length of your arm. I don't have a very long arm, but it's smaller than the length of my arm. It's really small. So it's easy to put tabletop. It uses fresh whole blood, so it's really easy to use. And you actually have 4 minutes to put the sample in the cartridge, which we'll see in a minute, and then run the test. And actually that holds true for all of these viscoelastic testing methods. You have 4 minutes, so it's kind of flexible, but you do want to have your patient right there, you know, in the room with you, obviously, and then run it over the machine. This machine requires pre-warmed cartridges just based on how it works and the engineering of this machine itself, but it doesn't take much blood. I mean, we typically use less than 1/2 ml in our patients when we use this machine. So it's kind of nice. You don't want to get a lot of blood from a lot of these patients because some of them are bleeding, and you don't want to take more than what you have to typically. Oh, just to back up, with this machine, it works, as you probably can see, there's no cup, there's no pin. It works very differently than the other machines in that there are 2 slides that rub sort of back and forth, and the machine evaluates some sort of physics parameter with the clot and the slides and the tension that's created there. I don't know the details because apparently that's proprietary information, but that's what I do know. So again, this is a small blood sample for this machine, and you basically take your whole blood, you put it into this cup, it goes into the pre-warmed cartridges, and it makes this circle, it fills up the circle, and then you just put it in the machine. It's really easy to use. And this is the tracing that you'll get in this machine. So what I really want to say is that these values are the exact same as the values we went over before. So every company uses different terms. So the Rotom uses different abbreviations than this machine, and the TEG uses a different abbreviation. But essentially, this is like that R value. So CT is clotting time. CFT is clot formation time, kind of like that K value that we learned about before. You have the alpha angle, and that's the same. And then this value here is that clot formation, maximum clot formation. So it tells you the strength of the clot. And this is, of course, the time period. And if you let this graph go for a full 60 minutes, you can actually see how the clot breaks down. So, so at 30 minutes, this Li30 value is lysis of the clot at 30 minutes, and then lysis of the clot at 45 minutes. And so you'll have a graph to look at, but also a time stamped numerical value as well, and the machine has normals for us. So we can really get a good sense of how is the clot forming, and then also how is it breaking down. So that's a lot of information about things that aren't as clinically fun. So at this point, we're going to dive into a little more clinical stuff and talk about therapies and some patient stuff, some patient examples. So therapies for clotting disorders are really cool and can encompass medications, depending on what the problem is, and of course, transfusion therapies. And so those patients that are hypercoagulable, for example, are gonna require specific treatments, and that's gonna vary widely from those hypocoagulable patients. This is a good example of a hypercoagulable patient. And I liked this picture because although I think it's kind of hard to see in this particular picture, I'm not a very good photographer, but this is an ATE cat, and he was a Sphinx, so it was really easy to see. If you can see here, he's got a little cyanosis of both of his back legs, and you can see that because of course he's hairless, so he's a little pinker up here, and he's cyanotic back here, and he had an ATE and no femoral pulses, sadly. But he was a good example of what really can happen clinically, and I thought it really sort of displayed that cyanosis that occurs, and we don't get to see that very often. So hypertrophic cardiomyopathy is one of those hypercoagulable states that we see, and we may not necessarily pick up on it with traditional testing. So blood counts may be totally normal, and PT, PTT may be shortened, or they may be totally normal. And then we go to do an echocardiogram on these patients. They have HCM, and they have a big clot in their atrium or a bunch of smoke. And so what I have found in clinical practice is that the viscoelastic testing really helps us to pick up on that. And I've got a clinical example toward the end of the talk. We also see hypercoagulability with PLNs and PLEs. Of course, IMHAs that are terribly prone to clot formation, various neoplasias, pancreatitis, and any sort of systemic inflammatory response syndrome can cause a hypercoagulability. So what do we do about hypercoagulability once we diagnose it? There are lots of options for therapy, and we really want to focus our therapy based on what we think is going on in the body. So for venous hypercoagulability, for conditions like, for example, IMHA, which tend to cause more venous clots to develop, we want to focus on things that are going to affect venous clotting more dramatically. So heparins that will interfere with the clotting factors, right? And this is the dose that has been reported for heparin therapy in animals. There's a really broad dose range here. Biggest reason is that there aren't enough studies really to tell us what's most helpful, which dose is most helpful in animals and for which conditions. So, you know, a dose for IMHA may vary and be totally different than a dose for, let's say, a PLN dog, for example. Low molecular weight heparins are also available. So we're looking at things like dalteparin and enoxaparin. And those therapies there's a little more information on those therapies, and more importantly, they're predictable. And the reason that therapy with low molecular weight heparins are predictable is because they're really small compared to unfractionated heparin, and the size of those molecules are just all over the board. So some of them are really big, some of them are really little. So its effect is really hard to predict. And with low molecular weight heparins, they're the exact same size. They don't interfere with thrombin at all because they're not big enough. And so we can evaluate the effectiveness a lot more predictably by looking at factor 10A levels. So that's something that clinically, if I'm going to reach for a heparin, I'm going to preferentially choose low molecular weight heparins if my families can afford it rather than traditional. And then we've got these other drugs on the horizon too. So I know our cardiologist has used rivaroxaban before for HCM cats, and there are other drugs available as well. I've never used abciximab or eptifibatide, but they're so easy to say. Anyway. Okay. So let's talk about hypocoagulability and blood product administration, which is really a lot of fun. And I think a lot more available than it used to be. It seems, at least based on our poll right now, that some people are using transfusion therapy in practice, which is real exciting to me. Hypocoagulability encompasses lots of problems too. And, oh, did I skip a slide? I think I did. You guys, I think I may have skipped a slide. Either way, because I skipped it, I'm just going to mention Clopidogrel. Clopidogrel, we typically use it for HCM, and essentially it's really helpful. We love it in those patients, and it's not very expensive. If you have questions about it, just pop them up on the Q&A or email or call me here. But let's get to the hypocoagulable patients. So those are guys that are thrombocytopenic, that don't have normal functioning of their platelets. It also includes rodenticide patients, vitamin K antagonist rodenticide patients, and hemophiliacs, which we don't see a lot of, but I do have a case example at the end of a really cool hemophiliac patient that I saw. So we do occasionally see them. Other factor deficiencies are really rare. Von Willebrand's disease is included in this. And then of course, patients that break down their fibrin like crazy. And the classic breed example is going to be a greyhound. Greyhounds can get traumatized and have been previously totally normal, but are hit by a car and then bleed like crazy everywhere. And, or they may get an invasive surgical procedure like an amputation and continue to bleed and bleed and bleed. And this is because they break down their fibrin like crazy, just as a breed predisposition. And so those guys are included in the hypocoagulable category. And then of course, disorders where we consume platelets and clotting factors. So what do we do about these hypocoagulable patients? Well, generally we're going to give them some sort of blood product, and the one we choose is going to depend on where the problem in their clotting is actually occurring. So that's where we bring in that viscoelastic testing modality. So blood products are going to include things like whole blood, of course, and you can get that from a donor that's been screened for infectious diseases. And from that whole blood, we have packed red cells and plasma, which if we freeze it within 6 to 8 hours is called fresh frozen plasma. And that's a great product because it has all of our clotting factors and everything that we might ever need. It's magical elixir, right? But if we wait for longer than 6 to 8 hours to freeze it, or if we wait for longer than a year after collection, it turns into frozen plasma. And frozen plasma does have a couple of deficiencies. It's not perfect. So fresh frozen plasma, again, like we talked about, has all the clotting factors, von Willebrand's factor. It has your albumin and fibrinogen. It's a perfect yellow-ish elixir. Heidi's laughing. She's my only feedback. Frozen plasma is also great, and you can use it for rodenticides the way that you would fresh frozen plasma. And we have a ton of frozen plasma here because we have an in-house donor program, and we may not necessarily go through all of our fresh frozen plasma. And so after a year, fresh frozen plasma is classified as frozen plasma, simply because it's hit that expiration period and it has depleted amounts of factor 5 and factor 8. Those are what we call the heat labile factors, and it just doesn't have as much of those. However, you can use it to treat rodenticide toxicity, which we're all not seeing as much of now as we used to, but we're still seeing it sometimes. Also has albumin in it, so you can use it to treat hypoalbuminemia. But remember, when you're giving fresh frozen or frozen plasma to treat albumin, you got to give a ton of it. And the dose for therapy to raise the albumin, a gram per deciliter, which is a good amount, but sometimes doesn't even normalize these patients, is actually 40 mils per kg, which is a lot. 40 mils per kg is an awful lot. So really, if I want to use plasma to raise the albumin, I give it to small patients because those are the only ones it's actually going to do anything in. I'll need too much of it to raise the albumin in a larger patient. We can use this for hemophilia B, which is a clotting factor 9 deficiency, and C, which is a 13 deficiency. Oh, there's a question. Thank goodness for you, Heidi. So the next question is fresh frozen plasma. Perhaps the other type of liquid gold. Thank you. That was just someone saying they laughed at my comment. I appreciate that so much. Yes, the other type of liquid gold, indeed. Thank you, anonymous attendee. Oh, I'm gonna have to rush. You guys, I gotta get to my cases.
Yeah.
All right, here we go. Here it comes. We're gonna rush through the next couple of slides, I think. Cryoprecipitate is fabulous, and it contains von Willebrand's factor 8, fibrinogen, and 13. But the great thing about it is that it's a small volume, so you can give that to patients that are euvolemic. So they haven't lost any volume. You can give cryoprecipitate at 10 mils per kg, and you're not overloading their blood volume. Lyophilized platelets are another transfusion product for clotting that we have available, and those are freeze-dried platelets. It's a new product. 10 years ago, there were very few studies on this, but we've recently, there have been so many studies in the last 10 years on these, and they've become commercially available, so we generally have them here. I do not give these to ITP patients because ITP patients will destroy them immediately. So it's kind of a waste for the clients financially, but they can be stored for a really long time. It's nice to have them on hand, and you want to use them in patients with low platelet numbers if you're planning an invasive procedure, for example. Okay, here come the cases, and then we're toward the end now. So this is Max, and Max is an 8-year-old male-neutered Himalayan cat who has HCM, and he has a really nice owner too. She stands out in my mind. I think I saw him like 2 years ago, and both her and her cat both stood out in my mind. Really nice owner, cat with really bad HCM, which is really sad. During his echo, we saw smoke in his atrium. Max, interestingly, had a totally normal PT, normal PTT, normal platelet count. And so with HCM, we often will put these guys on Plavix, Clopidogrel, which will hopefully decrease the tendency to form clots. So the question was, would we put Max on Clopidogrel as we normally would have in a cat with HCM to this degree with smoke in their left atrium or tiny little clots? And typically we would have. The thing is, I wanted to know what was going on with Max's clotting, and his owner allowed me to do some testing. And so we did run the VCM Viscoelastic test on him, and this was the result, which if we think about that nice curve from before, what we're seeing here is that this clot formation time is really prolonged, and then he forms this really crummy clot that is not strong at all. It's just a really bad clot that's not doing much. And so of course, at that point, we worried that if we would have put him on Clopidogrel, as we would have if we didn't have this test, he might have a bleeding abnormality. So we chose not to put Max on Clopidogrel. And I think that's a really good example of how this machine and how this specific testing changed our clinical approach 180 degrees. And then we have one more case, and this is kind of my favorite. This is Oscar, who's this really cute 3-year-old male-neutered mixed breed dog who was hit by a car, and he presented in shock. His PCV total protein was 37% and 4.9. And what I want to point out about this, of course, is that his PCV is pretty normal. And so you look at that and maybe you're not that worried, but what's not normal is his total protein of 4.9. So what we find with acute bleeding is that PCV may remain totally normal, but proteins will start to drop first. So whenever you've got a hit by car or any other traumatized animal and you're wondering about bleeding, if you see a low total protein, that should raise some red flags. So the remainder of his testing, his ALT was high at 980, real typical, obviously, for trauma. He had a normal CBC. And we did a quick abdominal ultrasound, not a full, just an AFAST. And he had abdominal effusion. We couldn't quite find the source of it. And he had a PCV total protein of the effusion. The PCV was 32. I don't have the protein on that. So pretty high. And obviously we're working diagnosis is a hemoabdomen. So what did we do? We turned him into a mermaid dog. That's really, we call this a mer dog because And this is something you can do in clinical practice. All you need is to MacGyver it with duct tape. Essentially what we do is we put a belly wrap on. The mistake a lot of people make with belly wraps is that they put the belly wrap on and it compresses the abdomen, and then the rest of this is just kind of left to do whatever, and it may not necessarily be effective at producing the goal, which is to return blood back to the heart so that the heart can perfuse vital organs in the brain and the rest of the heart. And so what we did, and what we typically will do, is I put a towel between the legs, a towel around the legs, a towel around the abdomen, and then duct tape from the toes all the way up the body. So that's how I place a belly wrap. It's true. And it's not just me that does it, I swear. So this dog was fluid resuscitated. He was placed on a fentanyl CRI. Following resuscitation with fluids, his signs of shock resolved. Obviously, we had placed his abdominal bandage, but we monitored his PCV total protein, and it had gone down. So 25% and 4.0. His heart rate had gone up, and his BP was going down. So the very good overnight emergency doctor gave 10 mils per kg of packed red blood cells, which was the perfect decision, and ran coags, which interestingly were normal. Well, coags were totally normal. The dog's bleeding. Is there anything else that we can do for him short of take him to surgery? And with hemoabdomens from trauma, I try to avoid surgery if I can, because oftentimes they decompensate on the table and they die. Now, sometimes you do have to go to surgery, and if you've exhausted medical management, that's a necessity, but we try to avoid it. And so when I came on service, as we were getting these coags back at about whatever time it was, 8, 9 o'clock, I decided to, of course, use my new machine. Now, this machine showed me that there was a clot that was forming, but it wasn't a good quality clot. So this graph is showing me a really poor quality clot, and it's taking a long time for the clot to form. Now, if I didn't have this, I would have looked at these coags and said, those are normal. I have no reason to give any additional therapies. I'm just going to continue to give him fluids, and he might have to go to surgery. Well, because I have this graph, I said, you know what, let's give him plasma and see what happens. So we gave him plasma, and then after the plasma, this graph, so this is his initial graph that showed a really bad clot, a really poor clot, and then this is his post-plasma graph that showed a really good clot, and he recovered with medical management. Now, would he have recovered without the plasma? Maybe, but this is a good example of how this type of blood testing changed my therapy and my approach. So yeah, I love this testing. Got a lot to say about it. Feel free to ask any additional questions, although we're really close to time, and I'm so sorry about that. It looks like I missed a question. Oh, I'm so sorry, I missed a question earlier. The question is, do you administer some type of platelet product to ITP patients that are actively bleeding? They are actively bleeding, most of them, to be honest with you. And we can administer platelets, like lyophilized platelets, to ITP patients, but they completely and immediately destroy them. So I find that in ITP patients, it's not helpful because their autoimmune reaction to those platelets destroys them immediately. And so it tends to be wasted funds for the owners. It's frustrating because you want to give some sort of therapy to solve the problem. And you have platelets right there in your hospital, but the body just destroys them immediately. So they don't last for any effective length of time, which is frustrating. So no, I don't use them in ITP typically. Ooh, do I have more? Oh, I have more. I have a thank you. You're welcome. Comment on sub-Q. So there's a comment on sub-Q plasma for rodenticide therapy. Yeah, so sub-Q plasma. Certainly, I think you can give it. If you can't get an IV catheter in place, for example, it's certainly not going to hurt. But the volume that you would need to give to actually affect the clinical outcome is probably going to be really uncomfortable for the patient. And then, of course, plasma is a product where bacteria can then live. So if you introduce anything into that, you're going to potentially see an abscess, and the volume that you're going to give during a therapeutic session to a bleeding patient will then probably cause bleeding at the site of administration. So really you want to give it IV if you can. I hope that answers the question. And then, oh, Molly is asking, he made it, didn't he? Oh, this is one of our technicians. She remembers the dog that we made into a mermaid. Yep, and he made it. He did really, really well. And then Dr. Black is asking, how long do you leave the Murdog bandage on? And really it depends on the patient. So I leave the bandage on until signs of shock are consistently resolved for a period of several hours. So, you know, 4 to 6 hours or maybe longer. And then most importantly, when you take it off, you want to take it off really slowly and gradually. So you want to, when you start cutting off your MacGyver duct tape, you want to start at the abdomen and work your way back to the toes and do it gradually over a period of a couple of hours, ideally, or minimally an hour. So again, a real gradual removal of that bandage. All right, I think that's it. Oh, most importantly. Oh, thank you guys. I grew that amaryllis. I'm real proud of it. Thank you guys so much for joining me today. I appreciate it.